My name is Dr Partridge, and I'm a breast medical oncologist at the Dana-Farber Cancer Institute in Boston. We presented at the San Antonio Breast Cancer Symposium results from the COMET trial, which is a study that randomized women to guideline concordant care, which is surgery with or without radiation, or active monitoring, which is doing mammograms and surveilling for the management of an entity called low-risk DCIS, which is non-invasive breast cancer or ductal carcinoma in situ. And low risk was defined as hormone receptor positive, low or intermediate grade, and some additional features on the anatomic review of the situation. So I had the good fortune of leading the COMET study efforts with regard to what's called patient-reported outcomes. They're just what they sound like. Patient-reported outcomes are hearing the voice of the patient, surveying the patient along the process of a study to understand their lived experience. And there are really robust research methods that help to delineate the patient experience. Those include what we call instruments or validated survey measures, where people in the past have answered surveys and we've done research to determine that what you're asking is actually measuring what you want it to measure. And so we use these validated instruments to look at the patient experience going on the study at baseline and then over time to see how the patient experiences things over time. And we often compare these patient-reported outcomes between study groups to see if a given treatment or management strategy impacts patients differently. So the findings from the COMET trial revealed that overall, in 2-year follow-up, which is fairly short for DCIS, that the disease outcomes, which include the development of any invasive breast cancer, were very similar between the group that got active monitoring and the group that had surgery. In fact, the active monitoring group had lower rates of invasive disease. Really important data and showed the initial safety to an active monitoring approach compared to guideline concordant care, which is, of course, the standard of care. What I focused on was measuring, again, the lived experience, the patient-reported outcomes of the women on the study. And what it reassuringly showed in those PRO analyses was that the average woman did well, regardless of which study group she was randomized to. Specifically, quality of life, as well as anxiety and depression, as well as breast cancer treatment-related symptoms, were very similar between the women who were randomized to the guideline concordant care versus the women who were randomized to a surgery approach. DCIS is an entity that we know is increased because women are getting mammograms. About 1 in 4 women who are diagnosed with breast cancer in the United States actually gets a diagnosis of DCIS. And that problem is something that we as clinicians struggle a little bit with because non-invasive breast cancer or DCIS is something that might turn into invasive breast cancer and harm a woman, but it might not. And yet we treat women with DCIS pretty similarly to women who we treat with invasive cancer with regard to how we manage it locally in the breast with either lumpectomy or mastectomy or radiation, particularly if a woman keeps her breast. And then we offer these patients endocrine therapy, hormonal therapy for the prevention of further events. And so given that, and given the fact that those are associated with both side effects and quality of life detriment historically, we've said, could we do less and still have good outcomes for these women, especially among those who have lower risk DCIS, where we're not sure about the natural history, but we suspect that many of them would never have a problem from the DCIS. So our reaction overall as investigators are that the COMET study shows us that at least in short-term follow-up, 2 years, there is safety to the approach of active monitoring in terms of invasive breast cancer events. These are short-term data though, and we want to see longer-term data before this is something that we think is really ready to offer to all women with lower risk DCIS who are interested in an active monitoring approach. The patient-reported outcomes are also quite reassuring because one could argue, and we thought that we would see a lot more anxiety in women who left their DCIS in place and were just monitored, and yet we didn't see that. The important thing to note, though, is that this isn't for everyone. Women who went on COMET may be very different than the average woman with DCIS with regard to her kind of psycho-emotional state. Many women anecdotally might have been offered COMET and said, no thanks, I'm going for surgery. So the women who went on COMET and were interested in being either randomized to an active management versus surgical approach, or who wanted active management, they didn't want surgery, and obviously were willing to be randomized, may be very different and likely are different from women who just say, give me the standard and I'm moving on. The COMET study results, both the primary outcome and the PRO data from the patients, really give us more information to understand the lived experience of women with low-risk DCIS, recognizing that the disease outcomes need more long-term follow-up to feel more safe about recommending it as a specific management strategy, and at the same time, early safety signal that there's no rush to getting to the OR with DCIS. And then from a patient-reported outcome, the women who are interested in this approach seem to do well from both an anxiety, depression, and from a symptom standpoint and an overall health-related quality of life standpoint, at least in the short term as well. The COMET trial was designed with safety at the foremost of our thoughts. And we didn't want to not operate on women who would be at high risk of some bad problem in the future. And therefore, we were very careful about our inclusion and exclusion criteria for women who are allowed to go on the trial. And one of the big ones was age. Women 40 and under were allowed on the trial. Women under 40 were excluded. And I'm someone that focuses on young onset breast cancer in particular, so I struggled with that, but I think it was the right thing to do because historically there are two big factors. One is that we don't typically screen women under the age of 40 for breast cancer. A woman who presents with DCIS under the age of 40 may have different characteristics about her DCIS. They're often bigger, they're often presenting with a lump, or that person is higher risk than the average, and that's why she was being screened young. And we didn't want to expose that woman to any undue risk before we could determine whether it's safer in a lower risk population in general. The second reason was that the biology of DCIS and breast cancer in general shifts a bit as you go down in age. And you tend to see more aggressive subtypes of breast cancer, including DCIS, in younger patients. So again, it goes back to the safety issues where we want to look at the safety of this approach in a group where we hope it's going to be safe before we can think about studying it in a group where the risks are higher and therefore intervening and not giving someone a particular intervention that's the standard would be testable. So there are a lot of future goals of the COMET study. First, we only have presented and looked at 2-year outcomes. We are planning to look at 5-year outcomes, 7-year outcomes, and hopefully 10-year outcomes to see whether the safety remains and how women feel over time in the COMET trial through the PROs. We also want to look at biomarkers, which means looking at the actual tumor cells and the cells around it and other features of the biomedical situation of the patients to understand a person going on to getting invasive breast cancer and what might predict safety and lack thereof of that. And that will help us to further risk stratify patients about the natural history of this disease, especially for the active monitoring group. We're also going to be looking at subsets of the women who developed invasive disease. What kind of invasive disease did they get? And what happened to them over time? And were there harms or risks that were undue in that situation? We'll also look at whether or not active monitoring worked better in any particular group than another. And we'll see these things over time as the study matures. Early onset breast cancer is unfortunately increasing in the United States in terms of the proportion of women being diagnosed, as well as worldwide. So I think it's critical that we put our feet on the gas even more than we have to understand why that's happening, to try and prevent that from happening from a population basis. And then when women do indeed get breast cancer at a young age, defined as 40 and under in most studies, how can we better treat them and better support them in their survivorship? Lots of work going on around that. Near and dear to my heart for this particularly vulnerable group is how can we help them to have babies after breast cancer if that's something they're interested in, and also take the best therapies to make sure that their outcomes are good. This is something that we've increasingly shown appears to be we can do it, recognizing that there are often compromises that need to be made. So a big call to action for breasties that want to support research for young onset breast cancer is when you're offered a study, participate in it if it makes sense for you. We want to learn from every young patient who gets diagnosed with breast cancer so that we can use your experience to inform how we care for women in the future. We want to do that for both women who are going to be diagnosed next year, as well as for our sisters and our daughters. We need to participate in research, and I hope that everyone listening to this, when offered a study, will participate or seek out research. Super important. And then, of course, if you're well-heeled enough, supporting research through philanthropic endeavors, giving of your treasure, your time, or your talents, whatever you've got to give, so that we can further the understanding and improving the care and the outcomes of anyone who gets diagnosed with a breast cancer, period, let alone at a young age.